Up next we have Janette Gale. Janette Gale is a health psychologist, consultant behaviour change specialist and founder and CEO of Health Change Australia. Janette is a leading authority on applied health behaviour change and has authored 2 textbooks on this subject. She works with corporate and public health organisations in Australia and Canberra to provide consultancy and training programs to embedded behaviour change support into clinical practice and health services in a broad range of contexts, and is going to give a presentation on evidence-based behaviour change, not negotiables, for consults and cardiac rehabilitation groups. Thank you, Janette.
Thank you very much, and good afternoon. For some of you, I think you've already seen this material if you were in our workshop yesterday, but hopefully that can just reinforce what we were talking about yesterday. Some years ago, a colleague and myself decided we made the questionable decision to review the behaviour change literature. Now, I don't know if any of you have ever tried to do that, but I will say that this is not, there we go, was a huge and daunting task. And I have to say that the behaviour change literature is absolutely massive. The problems are that not only is it over very many clinical domains, you can't just access a few databases, you've got to go looking everywhere in all sorts of different places. But there are also, as you would appreciate, hundreds and hundreds of models out there, a lot of them which actually accord really well with each other, but can be a bit of a minefield for clinicians. And this is the perspective that I'm coming from, is from a clinician's perspective. With all of these theoretical and delivery and program models, what on earth do you do when you have someone sitting in front of you, a client, who you know has some issues with behaviour change? So this was the question that we set out to answer, and those of you who know Health Change Australia and my colleagues and I know that you'll know that this is exactly the realm that we work with. As clinicians, how can we fit this into our programs and consultations? The good thing is that there are 3 critical sets of processes that, if you familiarise yourself with these as a clinician, they will help you dramatically to help your clients to be able to undertake the activities that you're recommending to them that will get them better health and quality of life outcomes. You won't be surprised to know that the first one is in fact patient-centred care. But that's not just having a nice bedside manner. It's not just delivering clinically appropriate care. It's also involving behaviour change support, collaborative decision making, taking the whole person into context, culturally, psychologically, cognitively, socially. Not an easy task. So the next 2 sets of processes will actually help you to do that. So we realised that when you look at the behaviour change processes, you can split them in 2. One set is the processes required to inform a behavioural intention, and that is, how do you get the person to that readiness line? How do you get someone to say, yep, I'm ready, I can commit? And some of these processes involve information. Now, we give information, but does that always translate into knowledge and understanding? And I'd suggest not, because it needs to do that to then create a motivation and accurate and clear expectations that can then form or feed into a decision that a client makes and then commits to taking action. That's when they can cross what we would call a decision line, where the person is actually indicating they are ready to take action. The third set of processes then needs to come into play, because once someone's ready to take action, that's not the whole story either. There are so many things that get in the way in our lives generally as people that you then need to help someone to be able to turn that action into self-regulation. And we can help there with the planning processes, but what I'm specifically talking about is identifying and addressing everyday barriers to change that occur for people: behavioural, emotional, situational and thinking. And the everyday thinking barriers such as procrastination that stop a lot of our patients or clients from taking action. So if you put those things together, you get what we would call a behaviour change pathway that you can use as a clinical decision tool in programs or consultations to decide whether, if the person is not ready, what's going on there? Where can I then intervene very briefly to help that person move through their pathway? If it's below the line, what are the barriers that are getting in the way of their immediate plans and stopping them from gaining self-regulation? Now, those of you, you've probably seen that we have a stand out there. There aren't too many stands out there in the foyer. And those of you who are interested, there is a little card that you can pick up when you come around and get your docket stamped, and it will give you some hints and guidelines about that. So please come and have a chat. Thank you.
Thank you. I think that was a lovely overview, Janette. Has anyone, this paper's open for questions, if anyone's got a question?
I think my only concern, not concern, I mean, you've got to try and change patients' behaviour, obviously. It's a time thing.
Yep.
How do you get the time to really work with them?
Yeah, and that's absolutely one of the things that concerned us too. In fact, if you use a consistent and clear methodology for behaviour change, you save time, and clinicians actually report back that they end up getting out of work on time, and you don't have the same people cycling through. Where you really save time is by targeting the information and education, and by targeting your response as a clinician to what the person really needs. You cut to the chase really quickly. You don't go round and round in circles.
Thank you.